Hello, this is Nadir Proxima, and I'm going to be speaking to you about carpal instability. First, let us take a time out. Carpal mechanics have been described by various authors. Navarro in 1909 talked about the columnar theory with a radial, central, and ulnar column. The link model was proposed in the 1940s, where the radius, lunate, and capitate form a link with an intercalary segment, the scaphoid being the one that crosses the proximal and distal rows and connects the linked system. Telesnik made a modification of the columnar theory to include the distal row. The distal row doesn't really have much motion at the CMC joints, so one can think of all of those carpal bones moving as one. And the ring modification by Lichtman, who described the carpus as a ring model, similar to one would think of the pelvis. It's hard to reach a consensus on the mechanics of carpal interaction, and no one model is perfect in describing the interaction, but it's nice to understand all of the different models and use a combination as the case. The carpus, of course, sits on the radius, which has a volar tilt of 11 degrees and a radial tilt of 22 degrees. There are two separate facets, a scaphoid facet and a lunate facet, and there's an intrafacet prominence. The lunate is typically about 50% covered by the lunate facet. The scaphoid has been described as a twisted peanut or cashew-shaped. The tubercle is volar and distal, that's this area, and the trapezium force tends to rotate the scaphoid into a flexed position. Because of the geometry and the carpal forces, there's a natural tendency for the scaphoid to assume a flexed position. The lunate is moon-shaped on a lateral radiograph, and that's why we call it the lunate, but it's very spherical in its articulation in the radius. And it articulates with the capitate, the scaphoid, and triquetrum, and sometimes the hamate. About 65% of the time there's a separate facet, type 2 lunate, which articulates with the proximal aspect of the hamate. It's narrower distally, and the natural tendency for the lunate is for it to extend. It's been described as a watermelon seed, where the narrow dorsal part tends to squeeze out, and the lunate wants to go into extension if left to its own devices. And so this leads us to the predisposing factors for DISI, or dorsal intercalated segmental instability, where the force of the capitate and the volar tilt of the radius and the narrow dorsal pole, those three things interact to cause the lunate to want to go into an extended position. Now let's move over ulnarly to the triquetrum. The triquetrum articulates with the hamate. There's a helical joint, and with radial deviation, the triquetrum goes dorsal and is flexed, and with ulnar deviation it goes volar and is extended. And this may dictate the entire position of the proximal row depending on your radial or ulnar deviation. So here is a demonstration of the triquetral hamate joint with radial deviation, the triquetrum going into a flexed position, and with ulnar deviation into a more extended position. The distal row is made up of the hamate, capitate, and the trapezium and trapezoid, and it's bound together with strong ligaments and really acts as a single unit with a minimal CMC motion, except at the little finger CMC joint where there's a lot of movement. The tendons, extensor or flexor, only insert on the metacarpals and the pisiform, and not on the carpal bones. And that's why the carpus was referred to as an intercalary link system. The carpometacarpal joints are relatively immobile, as we spoke about, and there are no tendinous attachments to the proximal row of the carpus. So the proximal row acts as a free intercalated segment between the radius and the metacarpals. The distal row is more fixed. When we're talking about ligaments, these are static structures that guide or constrain the motion of the carpal bones, and they can be looked at as either intrinsic ligaments or extrinsic ligaments. Intrinsic ligaments are entirely within the carpus. They may cross from proximal to distal or between adjacent bones, such as an interosseous ligament. Extrinsic ligaments are really thickenings of the capsule, and they run between the radius and the carpus. So they generally will cross the radiocarpal joint. They're named by the site of attachment, and the order goes from radial to ulnar and proximal to distal. So we call it a scapholunate ligament, not a lunoscaphoid ligament. And here's a depiction looking at it from a volar point of view on the left side and a dorsal point of view on the right side. Let's look at the dorsal ligaments. These are fewer in number and simpler, but probably less well understood than the volar side. These are the extrinsic ligaments, the dorsal radiocarpal, and that runs from the dorsal rim of the radius and Lister's tubercle to the triquetrum. So here you can see the dorsal radiocarpal ligaments, and the dorsal intercarpal ligament goes from the scaphoid all the way over to the triquetrum. Some fibers are attached on the lunate, and it interdigitates with the dorsal radiocarpal at the triquetrum. So there's a convergence, like a V, of those two ligaments. The dorsal intercarpal is considered one of the intrinsic ligaments because it runs from one carpal bone to the other. Now on the volar side, we have some extrinsic ligaments. On the radial side, the RADIOSCAPHOCAPITATE and the RADIOLUNOTRIQUETRAL, also known as the long radiolunate, the radiolunate or short radiolunate ligament, and the RSL, or RADIOSCAPHOLUNATE, which is part of the ligament of Testo and is really not a ligament, is more of a neurovascular frond of tissue. So the three that give it in structural strength are the RADIOSCAPHOCAPITATE and the long and short radiolunate. On the ulnar side, you have the ulnolunate, ulnotriquetral, and ulnocapitate ligaments. The RADIOSCAPHOCAPITATE, RSC, starts on the radial styloid and it goes across the waist of the scaphoid to the capitate. 10% of the fibers attach to the capitate, and the rest continue to arc around and join the fibers of the ulnocarpal and triquetral capitate ligament to form the arcuate ligament. And when this ligament fails, it typically fails at the radial styloid. The ligament acts as a bar over which the scaphoid rotates and flexes. It's seen on an arthroscopic view. So when you look with an arthroscope for orientation, the radius is on the bottom, the scaphoid is on top, and the two ligaments that you see are the RADIOSCAPHOCAPITATE and the long radiolunate. The more radial one is the RSC. Next to it is the long radiolunate or RADIOLUNOTRIQUETRAL, and you can see it labeled here in this arthroscopic picture. R is for radius, S is for scaphoid, RSC and RLT. And it's deep to the RSC, and it's more medial or ulnar to the RSC. And it's probably the strongest of the volar ligaments. The RADIOSCAPHOLUNATE, as I said, is also known as the ligament of Testo. It's some nerve fibers, and it's an embryonic remnant. We see it during arthroscopy. It doesn't have much mechanical contribution to stability. And so when you look at an arthroscopic view, you see that frondy stuff that's hanging down. That's the radioscapholunate. The radiolunate, or the short radiolunate, goes from the lunate fossa of the radius to the lunate. It's stout and strong, and in flexion it spreads out like a fan, and in extension it becomes more rectangular. So when you look at the ulnocarpal joint, we have the ulnotriquetral, ulnocarpal, and ulnolunate ligaments. And the ulnocapitate ligament is superficial to the ulnotriquetral and ulnolunate, and it's not visible as an intra-articular structure. But it does add to the arcuate ligament from the ulnar side. Now if you look volarly, there's a spot that's mostly devoid of ligaments, and that's called the space of Poirier. And it's in the midcarpal joint between the capitate and the lunate. And it's an area of weakness of the capsule, and when you get a volar dislocation of the lunate, that's the space that the lunate dislocates through. Let's take a closer look at the intrinsic or interosseous ligaments. The distal row interosseous ligaments are strong, and they're more likely to rupture or avulse than partially tear. These usually require significant force, like going over a handlebar of a motorcycle. The proximal row can elongate and stretch 50 to 100%, and partial tears are more common in the proximal row. The scapholunate interosseous ligament is the one that we deal with the most. It's C-shaped. It goes from palmar to dorsal, and it's open to the midcarpal joint. And of the three components, the palmar, proximal, and dorsal, the dorsal is the biomechanically strongest component. The palmar fibers are thinner, and the proximal fibers are really fibrocartilaginous, and they function to create a smooth surface. So here's arthroscopic views of the scapholunate interval. Picture on the bottom left is from the radiocarpal view, and the picture on the right is from a midcarpal view, where you can see the separation between the scaphoid and the lunate. The LT ligament is also C-shaped, like the SL ligament. It's also open into the midcarpal joint, but it's the palmar side which is stronger and thicker on the LT ligament as opposed to the dorsal side on the SL. And dorsally, the dorsal part, which is thin, helps to reinforce the dorsoradiocarpal ligament. So motion in the wrist joint is centered around the head of the capitate. That's sort of that center mass of the wrist joint. And remember that the proximal carpal row has no tendinous attachments, so it acts as a free intercalary segment. And here is the wrist in radial and ulnar deviation. So when we look at X-rays, we have to remember that X-rays are static two-dimensional representations of a really three-dimensional model. The X-rays we want to get include a true PA and a true lateral. So here's a true PA. The beam is going from posterior to anterior, and the shoulder is in a neutral position at 90 degrees. The elbow is flexed to 90 degrees. There's no forearm rotation involved, and that's considered a true PA. The true lateral is shot, again, with no forearm rotation, keeping the elbow at 90 degrees. And the beam can go from radial to ulnar or ulnar to radial. Doesn't matter. So here are two X-rays, and the one on the top is a PA, where the beam has gone from posterior to anterior. Excuse me. And the one on the bottom is an AP, where the beam is going from the palmar surface to the dorsal surface. And the way you can tell the lateral, the way you can tell the difference is that the AP view, where the forearm is supinated, the ulnar styloid moves more radial. So you see the difference of the position of the ulnar styloid. The top X-ray, the ulnar styloid is all the way ulnar, and that's taken with the forearm in neutral or pronation. And the bottom X-ray is taken with the forearm in supination. And you can see that the position of the ulnar styloid appears to be in the center of the ulna rather than all the way ulnar. Now on the lateral, this is the relation that we want to look for. We want to see the pisiform. Here you can see it outlined. The pisiform should lay between the tubercle of the scaphoid and the capitate. So that's a good lateral. We don't want to rely on the overlap of the radius and ulna to see if that's a true lateral, because that can change with forearm rotation. So a true lateral, look for this SPC relationship, which is the scaphoid, tubercle, then the pisiform, then the capitate. You can get additional views. This is a very useful X-ray taken in ulnar deviation, also known as a scaphoid view, because it makes the scaphoid go into extension, and you can see the scaphoid sitting tall. This can reveal any carpal instability, such as a scapholunate ligament tear. Another very useful view is the pencil grip view. What this does is slightly forces the forearm into a little bit of pronation so that the X-ray beam goes directly through the scapholunate interval. So here's an example of somebody holding a pencil and we're taking an X-ray, and you can see on the left side they have a scaphoid non-union, and on the right side they have a scapholunate ligament tear with gapping between the scaphoid and the lunate. Another very useful stress view is the clenched fist view with ulnar deviation. And so here, by clenching the fist, it forces the capitate down as a wedge between the scaphoid and lunate. And if there's an incompetence of the scapholunate ligament, it would force the two bones apart. On this radiograph, you can see the capitate is forcing its way between the scaphoid and the lunate. Notice that this radiograph was taken with the forearm in supination based on the position of the ulnar styloid, which has migrated over radially. Gilula's lines are another thing to look for on a standard PA radiograph. There should be 3 smooth lines or smooth arcs, one at the radiocarpal joint, one at the midcarpal joint proximal, and one at the midcarpal joint distal. And any step off or incongruity indicates a carpal instability. In terms of angles, the radiolunate angle is measured on the lateral view, and a line drawn through the radius should bisect the lunate angle. If the lunate is tilted dorsally, we call that a DC, D-I-S-I, dorsal intercalated segmental instability. If the lunate is tilted palmarly, we call that a VC, volar intercalated segmental instability. The angle between the scaphoid and lunate is derived by putting a point on either the proximal and dorsal, the dorsal and volar tips of the lunate, connecting those and drawing a perpendicular that gives you the lunate angle, and then drawing a line along the volar margin of the scaphoid, touching the tubercle and touching the proximal pole, and that gives you the scaphoid angle. So the scapholunate angle is increased in a DC pattern, and the scapholunate angle is decreased in a VISI pattern. So here the normal range is between 30 to 60 with an average of 47 degrees. What about the angle between the capitate and the lunate? The capitate and the lunate should be essentially collinear, and if the capitate is riding dorsal and the lunate is extended, That's one pattern, or the capitate is riding volar and the lunate is flexed. That's another pattern of instability. And anything more than 15 degrees is considered abnormal between those two. On a PA view, the carpal bone alignment should be in line with the center of the capitate and the third metacarpal. And you can also look for what's called the carpal height ratio. So the carpal height ratio looks at the length of the third metacarpal versus the line drawn from the radiocarpal joint to the base of the metacarpal. And normally that should be 0.54, meaning the metacarpal is twice as long as that space. And the tolerances are pretty small, as you can see, plus or minus 0.03. So in general, if you get a scapholunate ligament tear, there's widening of the scaphoid and lunate, the capitate migrates proximally, and the carpal height ratio is then changed. There are many other indices that are available for evaluating the position of the capitate, whether it's translated ulnarly, looking at ulnar translocation, and other indices, but the carpal height index is probably the one to really know about. Additional studies for evaluating carpal instability include a CT scan to look at the bony anatomy, an MRI to get direct information about the ligaments, and cineradiography. Cineradiography is very useful, especially if you have an office-based fluoroscopy machine where you can observe the wrist through an arc of motion. And sometimes certain instabilities, like a mid-carpal type of instability, only show up on this type of live action X-ray. Now, instability does not equal malalignment, and some people have hyperlaxity, which they're born with, but they're asymptomatic, and that's totally fine. Instability is an abnormal transfer of load across the carpal joint, an abnormal motion. So normal motion should be smooth, synchronous, without sudden alternation of clunks. Let's look at some definitions of carpal instability. One way to think about it is to look at dissociative, non-dissociative, complex, and adaptive. Dissociative is within the same carpal row. So carpal instability, dissociative, CID, for example, a scapholunate ligament tear or even a scaphoid fracture can cause carpal instability. Non-dissociative is between different rows. So mid-carpal malalignment is an example of non-dissociative. Complex are those where elements of both are mixed together, such as a perilunate fracture dislocation. And adaptive instability is that's caused secondary to deformity outside of the joint. For example, malunion of a distal radius fracture with dorsal tilt, which then causes a compulsory volar tilt of the adjacent segment. Another way to look at it is by timing, acute versus chronic. Acute is considered right away. Subacute is between 2 to 6 weeks, and chronic is something over 6 weeks. The direction of the displacement, such as the DISI, dorsal intercalated segmental instability, and VISI, as well as ulnar translocation, talks about the direction of the instability. Constancy, is this thing dynamic or static? And the etiology of the instability, whether it's traumatic, systemic, such as Ehlers-Danlos syndrome, or congenital. So the etiology of the instability can be traumatic, such as a complete or partial rupture of a ligament. Systemic, we talked about, things like rheumatoid arthritis, infection. Congenital, another example would be Madelung's, and adaptive after distal radius instability. Traumatic is what we typically see, and this traumatic instability can be caused by hyperextension and supination injury to the wrist, which is the typical fallen outstretched hand pattern. There's a progressive pattern of perilunar injuries that was described by Mayfield, when you fall on your thenar eminence and there's ulnar deviation of the wrist as your body goes over it. And you can also have it from hyperextension with pronation, and this leads to the reverse perilunar injuries or progressive LT injuries. That's typically from when you fall backwards onto the hypothenar eminence. So Mayfield's progressive perilunar instability is a continuum. Starts with stage 1 on the scapholunate interval, an injury to the scapholunate articulation. Stage 2, the injury progresses in a clockwise manner to the capitolunate or midcarpal joint. Stage 3, the lunotriquetral injury with a tear or rupture of the lunotriquetral ligament. And stage 4 is a complete lunate dislocation. Mayfield's perilunar instability is considered part of the lesser arc. The lesser arc is a pattern of injury that goes around the lunate. The greater arc is a pattern of injury that goes through the bones. So you can have a greater arc injury. Greater arc injuries are described by using the term trans. So if you hear a trans-scaphoid perilunate, it means that you have a scaphoid fracture and a perilunate injury. Or a trans-radius would be a radius fracture. So you can have a trans-radius, trans-scaphoid, trans-capitate, trans-triquetral, trans-ulnar styloid type of injury. Let's look at the lesser arc injuries first. Stage 1, a scapholunate ligament tear. That's the classic Mayfield 1. And along with the scapholunate ligament, there's usually a tear or injury to the radioscaphocapitate ligament, which allows the scaphoid and lunate distance to widen. In stage 2, there's a rupture of the capsule volarly through the space of Poirier, along with the injuries from stage 1. It's additive, and you can either get a capitate dislocation or subluxation, along with the lunate. On stage 3, it's a rupture of the dorsal radiocarpal ligament and its LT component. So the injury is considered to be going all the way around to the ulnar side, and the classic perilunate injury is stage 3. A perilunate injury is that X-ray that you see on the left, because the lunate stays in place and everything around the lunate dislocates. So in a perilunate injury, the radius and lunate are still articulating, and everything around the lunate has come out. That's why they call it perilunate. And the stage 4 or lunate dislocation is when the lunate actually comes out of place. So the lateral tells a story with these. When you look at the lateral here, here's a good-looking X-ray all the way to the left. And then the next X-ray, we see that the capitate is sitting dorsal to the lunate. It's not sitting where it's supposed to in the typical lunate facet. So that's a perilunate injury. The lunate has stayed in place. The capitate has come out of place. And the next thing that happens is, if the injury pattern continues, the capitate comes in and pushes the lunate out and takes its place in the radial lunate articulation. It pushes the lunate out, and that's called a spilt teacup sign or a stage 4 perilunate. So here's the X-ray of a case where the lunate is now completely dislocated volarly and the capitate has taken its place. That's the stage 4. Now there's an ulnar-sided perilunate instability that's been described by Alex Shin and co-authors, and the stage 1 starts on the LT side with the LT ligament disruption. Stage 2 goes around the ulnar lunate and ulnar triquetral and ulnar carpal, ulnar capitate ligaments, and stage 3 is disruption of the scapholunate and RSL. So it's similar to the Mayfield classification, but it happens on the ulnar side. This is less common. And here's a schematic representation. So here's a case. This is a greater arc injury because we have a scaphoid fracture and we have a perilunate dislocation. So here you see the lunate's in place, capitate's out of place, and there's a fracture of the scaphoid. Here it is when it's been reduced. The red arrow is pointing to the scaphoid fracture, and that's the lateral on the right. and this was treated surgically. These require surgery with placement of a screw to fix the scaphoid fracture and allowing the ligament injuries to heal on their own. Here's the range of motion. So when looking at the types of instability, we can look at carpal instability dissociative, which is the SL and LT injuries, carpal instability non-dissociative between the rows, radiocarpal and midcarpal, and adaptive and complex. So let's look at carpal instability dissociative, specifically at the SL injury. So when you have an SL tear, it looks wide on a clenched fist view. Anything greater than 3 millimeters is considered abnormal. There's a positive Watson test. The Watson test is done by taking the wrist from radial to ulnar deviation and from ulnar to radial deviation while maintaining pressure with your thumb on the tubercle of the scaphoid. If the scaphoid rides up and clunks, that's a positive test. Static instability is one you can see on a standard X-ray, and it requires rupture of the SL ligament and the RSC with rotary subluxation of the scaphoid and a widened SL gap. If this condition continues, you end up with a scapholunate advanced collapse, a slack wrist where the degenerative load transfer and abnormal load transfer leads to degenerative changes and arthritis. Here's some of the radiographic signs that you can see on a SL ligament injury: widening of the SL interval, that's called the Terry-Thomas sign. The shortened appearance of the scaphoid, it's because the scaphoid is flexed. This also creates the cortical ring sign, because as you look down the pike of the scaphoid, it looks more like a circle than a rectangle. And on the lateral view, the flexion of the scaphoid and the increase in the scapholunate angle. This is uncorrected. This leads to slack wrist. Initial changes are seen between this radius and scaphoid, and then between the proximal part of the radius and scaphoid, and then into the SCAPHOCAPITATE joint. And the last thing that's affected is the RADIOLUNATE joint. On the ulnar side, you can have LT ligament dissociation or disruption, and it's acute and traumatic, typically the reverse perilunate. If it's only an LT tear, you can have instability but no VC. If the extrinsic ligaments and surrounding ligaments are also torn, you can end up with a VISI or volar intercalated segmental instability pattern. This is what it looks like on a radiograph. Here you can see the tilt of the lunate volarly and the change of the shape of the lunate on the PA radiograph. There's also a disruption of Galula's lines noted here. The LT stress test is done by grasping the pisiform and lunate and shucking it up and down to see if there's instability and pain. Consider surgery when this is functionally a problem, and the surgery can involve either a ligament reconstruction or a lunotriquetral fusion. These are slides from Dr. Posner showing an LT fusion. The concept being that many people are born with a lunotriquetral coalition, and if we eliminate motion between the lunate and triquetrum, it does not cause much of a functional loss. That's the technique of the fusion with a bone inlay, and here's a healed fusion of the lunotriquetral space with range of motion. Now let's talk about non-dissociative instability. This is between rows, and ulnar translocation is one of the types of non-dissociative instability. There's two types of ulnar translocation. Type 1 is when the entire carpus, including the scaphoid, slides ulnarly. and this is typically from a ligamentous laxity such as rheumatoid arthritis, or it can be from trauma. The second one is where the scaphoid stays in place, but everything else slides over ulnarly. Here you can see the lunate and triquetrum are all translocated. Here's a case, this is a traumatic case, someone who was in a motor vehicle accident, and initial x-rays look relatively benign, but when you get the stress views, you can see there's a large gap there between the scaphoid and the radius. This prompted the CT scan to be obtained, where a small fleck of bone was noted between the radius and scaphoid, and the ulnar translocation was more evident, more obvious on the CT scan. This involves a rupture of the extrinsic ligaments as well as potentially the intrinsic ligaments. An extended carpal tunnel approach is taken to expose the flexor tendons and the median nerve, which are then protected radially to expose the osteochondral injury and ligament avulsion injuries along the volar wrist. The wrist was reduced, pinned in place. Suture anchors were used to repair and reconstruct the extrinsic ligaments, and the injury was neutralized with an application of an external fixator for 6 weeks to allow some healing. Really small fragments can also just be stabilized by removing the piece of bone and using a suture anchor. Here again, an external fixator was used to neutralize the wrist instead of relying on a cast to allow the ligaments to heal. Another variation of carpal instability non-dissociative is in the midcarpal joint. And midcarpal instability usually presents with a clunking of the wrist. It can be traumatic or atraumatic. And the proximal row remains in a gravity-induced flexed position, meaning that the whole proximal row is relatively flexed. Here on the x-ray you can see the lunate is really volarly tilted and sitting in a VI-SI type pattern. But the way to distinguish this type of instability is that the entire row is flexed, not just the lunate. And so typically an x-ray taken with a good lateral is what's necessary. And cine radiography is very helpful. While you're moving the wrist from radial to ulnar deviation, there can be a clunk. And so this is what it looks like. This is the test that you do by stressing the carpus going from radial to ulnar deviation and listening, feeling for that clunk. And the treatment for this midcarpal instability is two things. You can do a soft tissue reconstruction with a ligament reconstruction, or typically a four-corner fusion involving the capitate, lunate, triquetrum, and hamate. Eliminates the painful clunking. And the other category was carpal instability adaptive. So carpal instability that's adaptive is typically from an extrinsic force, such as a distal radius malunion, and can be treated with restoration of the anatomy, such as a distal radius osteotomy, to restore the tilt. The complex patterns are those that combine elements of intrinsic ligament injuries and extrinsic ligament injuries, such as this injury you see on top, where there's a dissociation of the CMC joints and part of the carpus has translated ulnarly, or in this bottom x-ray where you have a transscaphoid perilunate type injury. Here's a case example. Here you can see that there's a radial styloid fracture associated with carpal dislocation. So this would be a greater arc injury, a trans-radius greater arc injury, which was reduced with the reduction of dislocation and temporary pinning of the radial styloid fragment. And then this was neutralized with a plate placed along the radial column to stabilize the carpus. Thank you, and I wanted to thank Dr. Wolfson and Dr. Posner and others for sharing their slides for this talk.